Well, thank you for the introduction and good afternoon, everybody. It's a pleasure to provide an update on the results of the INTERACT3 trial, which were published in May this year, with a particular reference to the challenges of implementing evidence into clinical practice. It's not advancing. The slides are not advancing. These are my disclosures, which I mentioned this morning, editorial roles, leadership positions and funding from industry. So look, as you know well, and I know here in Vietnam, intracerebral hemorrhage probably accounts for at least a third of your stroke patients. It's a huge burden. And because patients with intracerebral hemorrhage are relatively younger than people with acute ischemic stroke, has a high mortality and a high disability, on a global scale, intracerebral hemorrhage is more of a problem than acute ischemic stroke. But all our attention's on acute ischemic stroke because we have proven treatments. But for intracerebral hemorrhage, it's been very challenging to get a proven treatment. It's hard. Patients die quickly. They're disabled. It's a critical illness, and the bleeding in the brain happens very quickly. So if we're going to try to improve the outcome, theoretically, we have to do things quickly. Just like in acute ischemic stroke, where we know now to do timely intervention improves outcome, maybe we should do it for intracerebral hemorrhage. We just need the evidence. So the whole purpose of the INTERACT3 trial was to determine the benefit of a care bundle, protocols to manage the patient, simple protocols that the nursing staff can organise under the direction of the clinicians. And that involved rapid control of blood pressure to a systolic blood pressure level of 140 millimeters of mercury to be achieved within an hour, rapid control of hypoglycemia with intensive insulin treatment with monitoring, reversal of pyrexia, and rapid reversal of warfarin anticoagulation with either fresh frozen plasma or prothrombin concentrate. And we implemented this as a system of care. So it's a different randomised controlled trial where we normally randomise individual patients. For this trial, it was to randomise hospitals to implement this as a standard of care. The definition of a care bundle is that the components of the care bundle are additive and that you apply the care bundle across all of your patients, not selecting, use it on this patient, not on that patient. This is a system of care. Now, normally, you would need proven evidence, but our hypothesis is that there was enough support for the components of our care bundle in intracerebral hemorrhage that made sense, are safe, and could be readily applied. There has been other evidence to show that care bundles work. This was a study called QUASC, which was to use a protocol of controlling fever, hypoglycemia, and swallowing assessments as part of a system of care. It was organised across stroke units in New South Wales and Australia, and it showed that this implementation across our stroke patients within 24 hours improved outcome, a highly significant treatment effect that you would not imagine any single component would work, but together it proved very powerful. Here is a care bundle but it's not a randomized controlled trial. It was a before and after study conducted at a single hospital in Manchester, United Kingdom. And in this ABC protocol for ICH patients who came in the hospital, it was about rapid reversal of anticoagulation, blood pressure control, and a targeted care pathway for patients of moderate severity or who are deteriorating could go to have neurosurgical evacuation. So the very severe cases or the mild cases, they were excluded. This was a targeted protocol. And across all of the phases, before, during implementation, and a follow-up post-implementation, there was a very impressive improvement in mortality. And across all of those phases, you have to make sure that there were no other reasons for the change, like the patient characteristics changed. They were less severe patients that came through, and according to the data for characteristics, these were all very stable. But what they showed is that very effectively controlling the blood pressure, more surgery, more active management in terms of intensive care, and very interestingly enough, there was a reduction in what is called DNR, do not resuscitate orders. I know this is something that may be unfamiliar to you in Vietnam, but in my country, in the West, there's often a perception that if the patient is very old, frail, and has a very serious condition like intracerebral hemorrhage, we would not let the patient linger and we would let them die early, and sometimes we even give some palliation in the first 24 hours, but it's quite controversial. My personal view is that we shouldn't do it, but many of my colleagues do it. So with this more active management, systems of care, organising the nursing staff, having protocols that could be applied easily across all of the patients, you see that there was a reduction in DNR, more surgery, more blood pressure control, to explain the improvement in survival. So this is the type of design that we used for INTERACT3. It's a complex design. It's called stepped wedge cluster. And what that means is that the hospitals were randomised in a stepped manner to all start as standard of care, to all move over to implementation of the care bundle. It has a lot of advantages in terms of just going about your routine care, not having to worry about getting consent from individual patients, but it also has a lot of disadvantage, which I've listed there in the pink, related to potential changes in background care. For example, like the COVID pandemic happened during the middle of our study. It's a very simple design, simple protocol. We had to have hospitals that were willing to follow our protocol. We had to have a local champion like the head of department or the president of the hospital who agreed that when the time was given, they would change their hospital system so that everybody would move over to follow the care bundle protocol. The timing was a 6-hour window from the onset of symptoms. We did a standard randomisation, primary outcome, safety, and we did a sample size where we estimated we needed over 100 hospitals in 10 countries, 9 of which were low to middle income countries, including here in Vietnam. We did pretty standard statistical analysis with our intention to treat. We did a whole range of sensitivity analysis to make sure that there were no other explanations for the results other than the intervention that we were evaluating. So this is a busy side. The red is control hospitals, they're control hospitals. The blue is intervention phase, where the hospitals moved over to implement the care bundle. For logistical reasons, we had to roll out our study in phases. There were 4 phases. And things were going well across the timelines, but then COVID started, and that caused us a lot of disruption. We had a lot of threat to our funding. Many hospitals had to stop in the study or delay participation, but we managed to get through. But you can see here that China started early and recruited well. We had a lot of hospitals in China through neurosurgical network as well as neurology, but most of the hospitals outside of China was after the onset of COVID. So in our analyses, we obviously need to consider the impact of COVID on patients, on systems of care and the outcome, which we did. And this is a similar picture, but this one is related to patients, whereas the one before was the hospitals. And again, you can see that there's different lengths of the colour, there's pauses between different phases, and there's pauses between the red and the blue at each hospital because of all of the challenges we had in doing the study, and also means this is what we needed to consider in doing our analyses. Despite all of the challenges, this was an enormous undertaking, by far and away the biggest research project ever undertaken in intracerebral hemorrhage. We kept all of the patients going steadily during the whole period. And this is how we present how we conducted the study. This is according to what we call consort requirements guidelines, reporting guidelines. So this is how the hospitals are randomized, and the various phases going from orange to blue. And then on the right is the way in which the patients, and we analyse the data at the patient level, and you can see over 7,000 patients randomised into the two groups. We lost about 10% of the primary outcome during follow-up because of the challenges, and we used a statistical method called imputation to help us in our analysis of the missing data. These are the baseline characteristics. These are no surprises to you. I'm sure the profile of patients is very similar to here in Vietnam. What's important about a clinical trial is that they're balanced between the two groups, and you can see that they are. And you can also see that the average for clinical severity is in the intermediate range. But you can also see that we have a very large range of clinical severity and hematoma volume. Most people presented hypertensive, which you would see with your intracerebral hemorrhage patients, hypertension being the main factor, but also with diabetes now in about a third of our patients, they come in with poorly controlled blood glucose. But I suspect here in Vietnam, very low rates of anticoagulation, and probably fever happens 2 or 3 days after the event, not within the first 6 hours. You know, blood in the brain is very toxic. As the blood breaks down, it causes neuroinflammation and an immunological reaction. The iron and hemoglobin breakdown is very toxic to the neurons and astrocytes. So maybe the fever takes a few days to develop. So as a consequence, most patients received intensive blood pressure lowering, and then much smaller proportion with glycemic control and reversal of anticoagulation. So this is a care bundle. The components together, what matters, but within the care bundle, the principal component is blood pressure control. And then the other thing is, which is important, is that you have to make sure that there is no difference in other management strategies between the ICH patients, surgery, intensive care, feeding, and this was very well balanced between the randomised groups. So this is the distribution of blood pressure and glucose and fever. We saw this data during the conduct of the study, and I was a little unhappy that these small differences would make an effect, but they certainly did, because this was the primary outcome. according to the modified Rankin scale, you can see there's a very clear difference in the outcome between randomised groups, and in particular, a big reduction in mortality. And this result in terms of the shift in the odds ratio was consistent between the primary and adjusted analyses. Now, for the secondary outcomes, it's a little bit more complicated because ICC means variation between hospitals. And if the ICC goes above 0.1, it means there's a lot of variation. So sometimes these measures are complicated by differences in the way investigators might have measured things like NIH stroke scale, but clearly improved mortality, improved quality of life, and a more rapid discharge from hospital. So, for the first time in the world, we have a randomised controlled trial that tells us that active management of ICH patients improved outcome. Not just particular patients, but a system of care. Blood pressure control as early as possible and other physiological barriers, control of other physiological parameters. So, the challenge to you and elsewhere in the world is, how do we implement this as a routine standard of care? And there are various campaigns going on to raise the profile, get the evidence into guidelines, and work around implementation. ABC ICH is an implementation project in the UK. Code ICH is a call for action in the US, and there are other systems of care occurring to improve this. In INTERACT3, we used a lot of strategies. It's hard to change systems of care. You know, in your hospital, it's chaotic. It's very hard to change things. We needed a champion. You know, in your hospital, you need to have a strong leader and you need to have support from the president. We had to give performance information, we had to give some feedbacks, we had to do meetings, we had to visit the sites, we got investigators together, like having a conference, we talk about our activities, we learn from each other, we give social media reports, and we had to push the staff to do everything. It was not perfect, and it was hard work. We've reported, I know that you can't see this very well, but we've reported some issues when we did the study in China, and we are writing up the challenges related to sites outside of China, including Vietnam. And there, you can divide this into doctors' issues, the systems of care issues, or the organisational issues. The first one that's quite common, you know, is whenever you're doing something a little bit more aggressively, you worry. Oh, I might cause harm in the patient. The nurses worry. If I'm going to control the glucose more often, could I cause hypoglycemia? So you have to work to make people feel comfortable, do the test on the protocol, give them some reassurance. And when they get more experience, you can remember when you started using thrombolysis, you were full of fear that you're going to cause hemorrhage. But as you become more confident, getting some support and testing it, you're gaining confidence. But I recognise a couple of other system factors is that in a low resource environment, like in Vietnam, things are expensive. Pumps, infusion pumps cost money. Who's going to pay for them? Antihypertensive, intravenous antihypertensive drugs cost money. Who's going to pay for them? And so there are cost issues in terms of how we deliver this protocol into routine care that we need to consider. And I know you work hard in terms of your guidelines and recommendations for the Ministry of Health to get approval. to get equipment and medication and other things into your standard of care. I apologise, this is a busy slide, but I just wanted to also tell you about these challenges to implementation from the QASC trial that I mentioned before. They tried to they've been working to implement the protocol for fever, swallow assessment, glucose control across all of the stroke units in Europe. And they show that you can change things, but there are limitations. And in this slide, you can see that on average, the amount of change they could produce across the hospitals, either high income or low income hospitals, was about 30%. They reached a ceiling. Why can you only make a 30% change? You can't make 100% change. And that is because our systems are not perfect. We can't change everything. There are a lot of barriers: time, equipment, resources, training, knowledge, everything. It's very hard. And so this is why generating evidence is one thing, but getting the evidence in practice is the next challenge. And that's why there's always what we call evidence practice gap. So there are some recommendations which are listed here in a systematic review about how to improve implementation. You need leaders, you need engagement, you need knowledge, you need support, you need incentives, these things. And so I think you need to understand with your guidelines and implementation strategies in Vietnam, to make things work, you also need to understand what the barriers are that you can work through the challenges to make things successful. So, to conclude, we've shown definitively that we need to take intracerebral hemorrhage more seriously. A care bundle works. Simple measures as a system of care through our stroke units, starting as soon as possible. Control the blood pressure, control hypoglycemia, rapidly reverse anticoagulation. I know with the NOACs there's some reversal agents coming. They're going to be extremely expensive for you. That's an issue for you in Vietnam, how you pay for that. And there is some evidence that targeting the surgery with some minimally invasive methods could work, and maybe we need to have some better procedures around how we offer minimally invasive surgery for our patients. And then in the future, maybe we have some hemostatic treatment. So when they come in and the CT scan shows that there's very active bleeding, maybe we should use something like tranexamic acid within the first few hours to tamponade the bleeding. We need some more evidence around that. But certainly from the point of blood pressure control and these other physiological parameters, these should now be part of routine care. Implementation now is the key challenge, and that's going to depend a lot on your local context, regional context, resourcing issues, nursing training, clinician training, and that is the challenge for the future in terms of patient care and benefiting as many people as possible from intracerebral hemorrhage. So I thank you very much for your attention.